I don't think there's anybody in the room who probably doubt the benefit of the multi-professional team, and I thank the organisers for giving me the opportunity to reflect a little with you on what has happened to team working over the last 50 years or so. I like this picture because it reminds us that as paediatricians we are supposed to be experts in growth and development. And you've already heard about the difficulties of maintaining growth in children with chronic kidney disease. It's also interesting to reflect upon this, the fact that Stuart Cameron mentioned that the only patients who were treated initially in adult units were actually young adults. So it was no different from adding on a few adolescents from the paediatric unit. But then things got a little bit hairier when we had the young children coming in, and they got even hairier when we started treating the congenital nephrotic babies and the like. And in fact, I always think it's a mirror image, really, because, of course, we have a difficult problem with adolescents. So do the adults have problems with their young adults. Middle adulthood is fairly compliant or adherent. And of course, they are dealing with a tsunami wave of geriatric nephrology. And in fact, that tsunami wave of geriatric nephrology now means that they usually send anything that's less than 16 years of age straight to the pediatric unit, whereas previously they were treated in the adult unit. Oh, a nice young patient. In fact, joking aside, that 16-year-old who might pitch up in the adult A&E and get sent to the adult unit is probably one of the patients at greatest risk, in my opinion, for management issues. Some of them actually, I think, suffer from post-traumatic stress disorder. Think about that. Some of the young people who've ended up with acute dialysis, ended up in chronic dialysis, ending up needing transplantation. But it's not only physical development that we should focus on. We are experts in growth and development. And I think it's more than just thinking about where we can dialyze and we can transplant. What is the quality of the end product? I think we have to remember that we do not cure our patients. We only ameliorate their chronic renal failure. Possibly more successfully with transplantation than obviously dialysis, but we do not cure our patients. Do you ever actually sit in front of a family whose child is newly diagnosed chronic kidney disease and say, we have no cure? Whereas, of course, that's what the patients are expecting. They may be expecting miracles. And, of course, this is my real favorite picture because it reminds myself of, in fact, in order to complete the dream, you need the team. It was mentioned, and perhaps not emphasized, that those of us who were battling away with end-stage renal failure, as it was then known, and now chronic kidney disease, actually were working in very stressful conditions. I myself worked single-handed for 7.5 years. Two of us for another 7.5 years. Is it any wonder that we see burnout, not only in staff, but in patients? We all know about the people who are getting burnout. That's the junior doctors because of their unsatisfactory working hours these days. But in fact, many of us only survive because of the support of a team. And that's number one there is surgeon. Now, in fact, we were very fortunate in Nottingham to set up a nephrourology unit. In other words, all the urological patients were nursed in one ward together. Makes logical sense. 45% to 50% of our chronic kidney disease patients have a uropathic condition or dysplasia. Many of them need vascular access. Many of them need repeat vascular and peritoneal access. Why not nurse them on the ward where the nephrology expertise is? So this surgeon is actually, of course, crucial. And there's another group of surgeons who are even more difficult to tie down. Of course, they are the transplant surgeons. And the transplant surgeon's sometimes domination of what may happen to our patients sometimes has to be challenged. I'll come back to that. We all know about the importance of the dietitians, the specialist nurses. I don't know how to dialyze either. I agree with Cyril. Yeah? Get the most experienced nurse you can. And just sign the bottom of the chart saying you think you know how much fluid should be taken off. And of course, there is a dimension here to care called psychosocial care. The impact of chronic kidney disease on families is enormous. No cure, don't forget. So how are we going to ameliorate it? How are we going to build their resilience? How are we going to help them get through the sticky periods? And therefore, the psychologist. And I think the psychologist, for instance, we were fortunate to have one who worked in the clinic. So there wasn't the question, oh my goodness, this patient needs a psychologist, they've got to be referred, they've got to go back again. They actually worked in the clinic and did preemptive things because, as well as the patient, what about the effect on the siblings? And if the family are able to say, look, little Johnny has started wetting the bed, the psychologist is able to get there early on. Early intervention, preemptive work. Why wait for the disaster? Let's preempt it. And the play therapies. Many of the things we do to our patients are traumatic. When I first started using lignocaine cream, I tried it out in the adult chemo patients, and they all wanted it every session. Why? Because a huge percentage of adult patients are needle phobic, right? And so a lot of our children are needle phobic. And in fact, you cannot really work without the value of having a play therapist as well. So that's the basis of a team that you need to support. So we all were brought up with this thing, or chronic kidney disease, and it goes dialysis to transplantation, but of course transplants don't last forever. We get back to chronic kidney disease. And you've seen the fact is that hemodialysis was full of disasters in the old days, especially when we had shunts. We had machines that weren't volumetrically controlled, and so the patients were like in a hospital bed, yeah? Like in a hospital bed. Is this the place where they're going to actually have optimal treatment? And this was mentioned earlier on. This goes back a long time. 1973, Barbara quote. Others claim the rigors of the treatment program was so catastrophic, for the child and family, and outlook so dismal that dialysis and transplantation should not be offered to children. An American assertion, but nevertheless. And I'm pleased to see that, in fact, the EUOPA, European Psychosocial Group, has come in from the cold. It's actually joined here in Glasgow for the 49th annual meeting. But they've had 48 meetings. Unfortunately, not one meeting has produced a guideline that we can quote. I think I don't disvalue the importance of the discussion and the swapping of knowledge, but in fact, there are very few. There are guidelines on bone disease, anemia, aware of the psychosocial guidelines. There are additions you will find out in guidelines that have been written that say that children should have access to this and this and that, but it's actually not specified in any way. So you see, these concerns have been with us all the time. Look at this one, treatment regimes for children with CKD are long-term, complex and intrusive. Reflect upon those words. Because despite that, you cannot stop momentum, and people learned very quickly how to do things a bit better, and you've seen these papers quoted before, and Germany, America, France, they were all doing it. So of course, there is still a large dependence on hemodialysis in some units. This is a very rare picture taken in our unit because we were very proud of being actually needle-free. We were needle-free because in the 1980s, the oncologists developed Hickman lines for the giving of multiple chemotherapy and sampling. And all you had to do was to take a Hickman-type line, and stick it into the internal jugular, and you had needle-free hemodialysis. And if you're lucky enough, you can have, like this lad, needle-free hemodialysis, the same line for 4 years. For 4 years, unbelievable. But it can occur, and it's a bit like peritoneal dialysis. You can get some patients who never have infection and some people who have a lot of infection. But that's a great boon. No needle, no 16 gauge needles, twice in your arm. I always remember the first child at a summer camp that we went to. She wouldn't go in and swim. She had a long sleeve dress. And I said, well, why won't you swim? And eventually she pulled back and she said, would you want to have this big fistula on our arm? 2 16 gauge needles a week, 3 times a week. Would you want that? And that makes us reflect a little bit. So tunnel catheters, in a little survey that we did from a group we set up in 2000, still showed that tunnel catheters are actually things. Obviously, if you're a Bouchelor in Paris with 85% fistula patency at 2 years, then you'll do a lot of fistulas. But the majority of people do have access to needle-free hemodialysis. Of course, in the 1980s, we also brought in peritoneal dialysis, CAPD. Maybe you're all very well carrying out CAPD, but this adolescent didn't walking around looking 8 months pregnant. And of course, we moved from there to CCPD, and we now have small portable automated machines. So this brought with us the opportunity and the availability to dialyze children and infants. But I would say to pause a moment and say, we would send this child home on peritoneal dialysis with fluid exchanges, with feeding, with medications, with measuring blood pressure, with the mothers having to do the cooking, the cleaning, and everything else on top. We were setting up mini pediatric intensive cares at home. And therefore, one must reflect that, can you do that? Can you really put the burden of care on the parents to do it? On the other hand, if you live hundreds or even tens of miles away from the hemodialysis unit, getting access into there with transport is very difficult. When I first arrived in London in 1985, they had home hemodialysis for adolescent patients. They would take a crane and put it over the roof of the house and drop a porta cabin into the back garden and hook up for home hemodialysis. Well, we soon got active and transplanted all the patients. They didn't know this home hemo disappeared. But I know it's coming back. But the same questions still are in my mind. Have we given adequate support? It's very easy to say that you can do these techniques, but is there the support available? And of course, necessity is the mother of invention. For peritoneal dialysis, thou shalt not do peritoneal dialysis with a colostomy. Well, when you're 200 miles away, and you've got a colostomy bag, and there's no peritoneal dialysis unit available, you put in a PD catheter. That child did not have peritonitis for 8 months. Of course, he had it when he came into hospital for another procedure. So we learned very soon on that the peritoneal dialysis program, the collaboration with a pediatric surgeon is vital. You have to have a nurse available. If you're at home and you've got a machine next to you, next to your child's bed, and the machine goes beeping in the middle of the night. I mean, many of us have difficulty finding an alarm and confused about what we're doing, yet alone having a machine that is in fact connected to their precious child. So you have to have people available who can give advice. You have to have people who go out to the homes and assess the suitability for them. But on the other hand, I would counter against one thing which we say, which is that some people say they can't have peritoneal dialysis, the parents are of too low intelligence. That's the greatest insult you can give to some of these parents, because in fact some of the lowest intelligent parents are the ones who do the PE the best. It's the engineer type parents who want to fiddle with the machine that actually give you the problems. Do not underestimate the burden of care. Very few studies have been done about the burden of care on these families. We're beginning to get some information now. So what about respite care? If you're looking after your child all overnight. Michelle, how nice to see you. Michelle Breuer in my throat, see you back there. Flight from Paris was to be delayed. Anyway, home visits and respite care. What do I mean by respite care? Well, the truth of the matter is every day except Sunday. You know, giving a break if the patient has actually urine volume, why not give them a break on a particular day? It's very essential. We all need a break. And I think we should be considering an aggressive nutritional support. Now, one of the things that we did to say that nutrition is important, nutrition and dialysis combined together, not just filling them up with calories, Cyril, but giving them a bit of dialysis as well may be important. And one thing that we did was to put in gastrostomies. So in fact, through the original STAM gastrostomy, we would put in a button for feeding, we would put in the PD catheter, and we would do a partial lumpectomy at the same time. And in fact, we published in 1998 the fact that we got 61% of the calories and protein requirements going into gastrostomy, and that these patients maintain their growth rates. And we started early, so they weren't down at -3 standard deviations. They were much. And in fact, that's been corroborated, and Leslie's still in the audience, but the International Paediatric Registry confirmed that those who were given gastrostomy feeding actually were still better height velocities than those that weren't. Some people said, why are you putting in gastrostomies? Because we put a few of those in, and they got terrible peritonitis, peritonitis. But what was the status of the patients before they put the gastrostomies in? The truth is they were in end-stage nutritional failure. And when you're poorly nourished, go to Africa and see what the results are. You're very prone to infections, yeah? And if you're poorly nourished. So the thing is to go early. So we have now available to us a choice of therapies. And certainly in this group of European patients that we surveyed, overall it was 50% PD. But of course under 5s, APD, avoiding the hemodialysis, is predominant. Whereas in the over 5 groups, hemodialysis is creeping up more and more, and in the over 10 group, probably hemodialysis is probably the choice. But the big question to be asked really is, why are we bothering with dialysis at all? Most of these patients are going to return to dialysis on another transplant. So why not try to preserve their vascular access? Why not try to preserve their peritoneal diaxis? And I think, this consideration, I see at this meeting there's 1,920 patients in the French registry that have been reported, yes, for preemptive transplantation, and a 45% reduction in the rate of graft failure with preemptive transplantation compared to patients who've been hemodialyzed before. But the preemptive transplantation rate is still only about 30%. So why not? Why not is the question. And part of the reasons may be, in fact, you look at it, is that not all the units offer even preemptive living rate donor. This is 14 units of a survey, and in fact, in 2 units, it's against the national laws to offer preemptive deceased donor transplant. Do we believe that transplantation is the best modality of choice for children? Talk to me later if you want to debate it. I think it's all self-evident. But part of the reasons about this choice of therapy is young people should be involved in the choice of therapy. We've moved from a paternalistic approach to saying to a more autonomous approach. Nothing to me without my agreement is what goes for adults, but it should also go for children and what's in their best interest. And these families really need counselling, and they need counselling by people who are going to support them through the therapy, like specialist nurses, like psychologists, like social workers, like having home visits before choice of therapy. But this requires time and staff time. And unfortunately, many of these units are deficient in it. And it's a sad state of affairs, I think, that it's even more difficult now to maintain the staffing with what we call the psychosocial team in many of these units. And is the choice of therapy influenced by the expertise? Well, there was a time when PD catheters were put in by pediatric surgeons and stuck them in at the end of the list. This most vital access was the last patient added to the list. We got that turned around a bit. But it still is, you cannot do dialysis if you don't have the access. So the liaison with pediatric surgeons is very important. And of course with jugular venous catheters now, although we use pediatric surgeons, we've now got, in many instances, interventional radiologists. This is all very well if you've actually got your units situated in a place where these specialties are available. And of course that's one of the big issues. Should we be centralizing more in order to justify the cost and the numbers for the team members that we require? Some things that are impacting upon our treatment. Of course, one of them is the fact is our patient demography is changing. We're now accepting onto end-stage renal failure programs or renal replacement therapy programs patients who have mental retardation, many other physical problems. So these are complex patients, right, where the parents are expecting us to perform miracles. And in fact, of course, our renal replacement cycle should have another arm to it. Another arm has certainly been introduced by the adults to cope with their large number of elderly patients, which is to say, we will give you chronic renal failure treatment which does not involve renal replacement therapy. It's so-called conservative management. And many patients are accepting this. And perhaps we should be brave enough to accept it or promote it or discuss it at least in some families where there is where the child has other major problems. So in other words, the problems in medicine are not medical, they are ethical. They're ethical. And we're faced now with dilemmas about acting in the child's best interest, assembling all the available evidence, and attempting a consensus whenever possible. If you don't get consensus, you get the situation where you've got the Charlie Gard case, which of course had intervention from the Vatican, Donald Trump, Tom Cogley and all. In fact, where a child with severe mitochondrial dysfunction was on a ventilator, could not smile, could not hear, absolutely futile to continue, where the Greater Ormond Street staff ended up being vilified. Staff dedicated to the treatment of children being vilified and threatened, because they didn't carry out the treatment that the press were pushing for. And so when we get that situation, who is going to say no? Well, all I would say is I've been involved in the formation of ethics of clinical practice committees, and you need to take your problems and discuss them and get some reflection from outside the team. And the other big problem that we're facing is, of course, we are victims of our own success, which means that we've now got a cohort of young adults who we have transplanted. And this is one of the papers that's been, my publisher's been quoting quite a bit, that transferred to adult transplant units, 35% of them failed within 36 months of treatment. And the big problems are really that of adherence. Young people are dependent upon parents, so you think they're fairly adherent, but adolescents' adherence is only 50%. There is no patient who is 100% adherent if you consider that they need to take the tablet at this particular time for this. Most people are generally adherent, but these are the figures. No disease is so catastrophic that all patients would take their medications, even adolescents with ALL or Hodgkin's. And of course there has been actually interest in the brain physiology development of these patients, where in fact there may still be diminished frontal lobe development, which is the area associated with these feelings of invincibility, impulsivity, and feelings that they know what is best. I don't know why that happens, but it jumps off the screen. So what we have had to do is to say, we have treated them, we have fed them, we have dialyzed them, we have transplanted them, and then they're going to crash into adulthood. What a disaster. But of course we are not alone. It's the same thing with diabetics, cystic fibrosis patients. There's a huge problem of transition. Who should be looking after adolescents? How many of us have an adolescent unit in our hospitals? Does it really matter? Yeah? As Jochen, should we really be cared? But we have to change our strategy. And in fact, I suppose of any paper, I'm more proud of this than anything else. And I haven't got time to go through it. But the transition issue is alive. And how do we cope with that? Well, I wanted to tell you about adding one more person to the multi-professional team. There are others you can add, renal pharmacists and all the rest of it, but the one person we've added in the last decade has been a youth worker. Youth workers are people who help and support young people to build self-esteem through a range of personal and social developmental opportunities, to have their voices heard in the front of decision making at different levels. Nothing to me without my agreement. To offer support in transition. And in fact, we have shown some benefit from that, but the young people are the people who say, we value this people. Can I show a p-value? Well, from Oxford, they've shown a p-value in the outcomes of transplants. And of course, one failed transplant is going to cost £60,000 a year in terms of dialysis. It makes sense to be employing youth workers. And the equivalent in the adult unit is a young adult worker. Okay? But we need this team to address the stress and burden of care. We need this team to provide psychosocial studies. We've got health-related quality of life, which of course is going to show the parents are more stressed than the children. But there are variable results in quality of life. We did quality of life studies in our own unit and in the UK compared to a normal cohort of children in the local school, and some of the children in renal failure came out higher than the local population. Now you may think that's counterintuitive. Why should they come out higher? But in fact, they're actually being respected and listened to, and in fact they may be doing better than we think. And we should be aware of this, because probably the biggest killer in adult nephrology is probably depression. And the way that they probably cease treatment or muck around with treatment or get their hypokalemia. And there are studies showing that some of these young people, I don't quite believe that, but it's something that we should be keeping an eye out for. If you ask all patients with chronic conditions, renal disease, chest disease, they will tell you two things. We need more information and more support. Everybody needs information, and that information needs to be given in many different ways. I mean, it may be an app. Ooh. You take the lights out on me. Maybe in the form of an app, maybe in the form of a video. But that support is so important. And I think we should not underestimate the financial impact on our families. And it's finance that is going to finance the team, and the finance has to be obtained from somewhere. So in conclusions, ladies and gentlemen, the child and the family with CKD need 3 prescriptions. We have sometimes focused on the medical prescription. To make them grow, we need the nutritional prescription. To make them thrive in a total proper manner in society, we need psychosocial prescriptions. Everybody likes showing some great pictures at the end of their talk, just to remind ourselves. Here's a little 7-year-old girl squinting with her cystinosis. Her 2 siblings weren't affected. And here she is, of course. So that's a wow picture. But of course, she's not cured. Yeah? She now attends the epileptic clinic more often than she attends the renal clinic. Yeah? We can help them on their journey. Yeah? But we have to have the tools to do it. And I think you need a multi-professional team to do it. And of course, we're here 50 years later on, but Hippocrates said this in the 5th century. It is not enough for physicians to do what is necessary, but the patients and attendants must do their part as well, and the circumstances must be favourable. Thank you very much.